Hello. Let's get started on our first postoperative presentation. This is related to ankle osteochondral deficits. We briefly mentioned in the first slideshows that these problems at the ankle tend to happen at the talus, and specifically at the joint between the distal tibia and fibula and the talus. So just so you see here, you'll see at 3, the number 3, we have the talocrural joint. And it's this area of the talus, the most proximal aspect of the talus, where we tend to have issues with cartilage breaking down or actually tearing. And so you need to kind of keep this area in mind as where we're likely to have the biggest injury to cartilage at the ankle joint. I do want to do a little bit of an anatomy review with everybody first before we go into the specifics related to these chondral deficits. Just to remind you, you'll see here that we have the talocrural joint, again, between the tibia, fibula, and talus. And I just kind of want to remind everybody that we have that talocrural joint is primarily focused on dorsiflexion. And then just kind of this picture just kind of gives you an idea of what the rest of the foot looks like. So we have what's called the rear foot, which is the talus articulating with the calcaneus. We have the midfoot, which are the other tarsal bones. And then we have the forefoot, which is the metatarsals and the phalanges. And you'll see here, we have this beautiful cartilage. So that's what the white is. This is an actual cadaver that's been cut kind of through the back of the ankle foot. And so what you'll see at the very top, that bone is, again, that's the tibia. And then we have the talus and its articulation between the tibia and the talus. And so you'll be able to see that beautiful white, thin tissue is actually the cartilage. And this is what tends to get damaged the most in the ankle. So let's just kind of review movement of the ankle. Again, we're primarily looking at the talocrural joint. And we need to recognize that that joint is focused on dorsiflexion and plantar flexion. So that joint allows us to get into as much dorsiflexion as we can. We're going to talk about how important that is with gait. I am just going to go over a little bit related to gait here. And then below that joint, we have what's called the subtalar joint. The subtalar joint is between the talus and the calcaneus. And at that joint is where we get most of our pronation and supination. So you need to keep both of those joints in mind as we're considering rehabbing following an attempt to improve the cartilage at the talocrural joint. So again, talocrural focused on dorsiflexion and plantar flexion, but just below that between the talus and the calcaneus, we have pronation and supination. I also want to review with you the muscles that are used for the different motions. So we just talked about dorsiflexion and plantar flexion muscles that we need to consider as we're rehabbing these patients following some sort of cartilage surgery. The primary plantar flexors are going to be the gastrocnemius as well as the soleus. And also to consider the muscles that also help with plantar flexion would be the flexor digitorum longus, flexor hallucis longus, the plantaris, and even the tibialis posterior. So all of those muscles are things we have to think about as we're doing our rehab following surgery. For dorsiflexion, our primary muscle is the tibialis anterior, and that needs to work very well, primarily eccentrically actually, during movement. And so that's, again, another muscle we need to make sure is firing. Other dorsiflexors are going to be your extensor digitorum longus, extensor hallucis longus, and your peroneals also do some dorsiflexion. And then as we think about the foot, we need to think primarily about the midfoot and how we control the midfoot, and that's primarily done by our inverters, or specifically the tibialis posterior. So the tibialis posterior, that's the primary action of that muscle, but we also have the flexor digitorum longus and the flexor hallucis longus, which also help with inversion. Again, this is more of a midfoot movement, and so it's not something we need to think about as much following the surgery, but I just want to make sure, again, for completeness, that you're aware of those muscles and what they do. And lastly, we have our everters, which are going to be all of our peroneal muscles, as well as our extensor digitorum longus, and they evert the foot, but actually their primary goal is to eccentrically control the midfoot during stance, during gait as well. And so again, I don't want to go into a lot of detail here, but I think it's important that we're all on the same page when we talk about gait and what we want to be thinking about. Again, with this type of injury and surgery is primarily dorsiflexion and plantar flexion, but we also need to be aware of what's going on at the midfoot so that following this surgery, we can make sure that the midfoot has good control. And the way that our midfoot works on control is actually through two primary muscles, the tibialis posterior and the fibularis longus. And what I want you guys to get from this slide is the idea that you'll see the tibialis posterior here on the right, and that muscle actually comes from the medial part of the foot and ankle, and then attaches to multiple bones you'll notice on the midfoot, as well as attaching to the second, third, and fourth metatarsals. And then our fibularis longus comes from the outside of the ankle and comes in and attaches to the first toe. And it's really important that they work together during gait, and we'll talk about that just briefly, but I want you to be aware of those muscles and the anatomy here so that you can understand, again, what we need to think about as we're working with these patients following surgery. So I just want to briefly talk about the gait cycle so that we're all on the same page. Again, these are things that, as we continue to talk about other issues throughout our postoperative classes related to the ankle foot, I just need you all to be aware of the wording that we're going to use, the vocabulary, so that we can all understand it and work through these things together. So what we call initial contact is going to be the very first part of weight bearing. So you can see that on the left here in this picture. And that's where we're just putting the heel down, in this case on the right leg. So you're going to see the right leg is going through initial contact into what's called loading response. And so we all know that at that point, from initial contact, our foot is in neutral, but then it goes into a little bit of plantar flexion as we put more weight onto the foot. And it's really important that at that time we also have what's called controlled pronation. And pronation is that flattening of the foot, and it allows for shock absorption through our body from the ground. The primary muscle that's needed for that is tibialis posterior. And again, we also need to be able to plantar flex about 15 degrees. I'm not going to worry about what's going on at the knee and hip at this time. Just be aware that there are also things like knee flexion, some slight knee flexion when we go into our loading response. And our hip is stable at 20 degrees of hip flexion. So we then have what's called initial mid-stance to late mid-stance. So that's when we're basically on one foot. And you'll see that when we're on one foot, in the case of that picture, it was the right foot, then our ankle needs to go from slight plantar flexion into maximum dorsiflexion. And maximum dorsiflexion is usually about 10 degrees past neutral or past 90 degrees. We also then need to go from pronation to supination. So we need to be able to control coming out of that flat foot and into a more rigid foot by late mid stance. You'll see also by late mid stance that we need to have full knee extension. And then from terminal stance to pre-swing, so the end of that gait cycle. So again, this is the right foot. The right foot would be starting to have the heel come off the ground and then the toe push off. And during that time, we need that 10 degrees of dorsiflexion. and we go from that 10 degrees of dorsiflexion into plantar flexion. So again, this is where following this particular surgery that we're going to talk about in a little bit, we need to have good dorsiflexion. We need to have 10 degrees of dorsiflexion and then allow ourselves then to go into plantar flexion. So that mobility of going from 10 degrees dorsiflexion to 20 degrees of plantar flexion is very important. Our knee also needs to be able to have full extension, and our hip also needs full extension. So 10 degrees of hip extension. Very important for gait. And all of that works together with our ankle foot to allow for push off and pre-swing, which then allows us to propel forward. And then with swing, we don't need a whole lot of anything from the ankle. We just need it to get to neutral. We also need the knee to be able to go into flexion. We need the hip to be able to go into flexion. So we don't worry too much about swing with these patients. It's primarily making sure that they can have good ankle foot mobility and stability during the stance phase. So let's move on here and now talk about the pathophysiology of this particular pathology. So you'll notice that for all of our post-op slides, for all of our presentations, we're going to follow the same basic organization. So we're going to start with talking about the pathophysiology. We then will go into reasons that the surgery might be necessary. We'll talk about the surgery itself. We'll talk about any preoperative issues or things that we might want to do before the surgery, and then we'll go into the actual rehab. So in the case of our osteochondral deficits at the ankle, again, we're thinking about the cartilage, and what tends to happen is that there tends to be an injury to that cartilage as well as possibly the subchondral bone. So if you remember when we talked about cartilage in the last slideshow, we talked about the fact that there are multiple layers of cartilage that then attach to the bone underneath. And usually what is going to require surgery is when the cartilage is damaged so much that we've gotten injury to the bone underneath as well. And what's different about this problem is that the tissues actually are softened. That subchondral bone becomes softened, which is different than arthritis. And we'll spend lots of time talking about arthritis in these classes. But with arthritis, we actually have hardening of the tissues and sometimes bone spurs and things like that. Whereas in this problem, it's more of a softening of the tissue. The tissue becomes less stable. It usually is going to occur with people who are generally, usually younger ages, and following some sort of trauma. So ankle sprain is the most common trauma, that if it's a really bad ankle sprain, you'll see here that about 6.5% essentially of any type of ankle sprain can lead to then tears and injury to the cartilage. And so if you have the type of sprain where you get some sort of compression or shearing, rotation type force, then you're likely to cause tears in the cartilage, as well as obviously ligament injuries. To diagnose these cartilage problems, your patient's likely going to tell us that they have some sort of deep aching pain that gets worse with weight bearing. And it's a deep ache, and I think that's kind of the most common way that you're going to hear this. It's different than, again, ankle sprain pain where they feel it more superficially on the outside. They can usually point to it. They can say they feel unstable. This is going to feel much deeper. And sometimes, just like with other types of cartilage injuries, they may feel locking or catching in the ankle. And so they feel like sometimes that the ankle just gets stuck. For providing really good diagnostic techniques, a doctor's going to require an MRI, and it helps to diagnose as well as stage it. So I have a couple pictures here. You'll see on the left, we have an x-ray, and this damage was enough that it affected the bone, and so therefore that bone can be seen as damaged on the x-ray. And to the right, we have an MRI. And again, this is going to show more of your soft tissue, and it's very obvious in that MRI that we have cartilage damage. If this patient is not having surgery, and sometimes the doctor will say, we're not going to do surgery, we just want you to do some sort of non-operative rehab. And if that's true, then they're oftentimes going to put them into some sort of boot for a period of time. We would prefer a boot rather than casting. You'll see here that sometimes they will be put into a cast, but we would much rather have a boot because it allows for us to take the foot out of the boot and actually do some mobility, which, as we'll see, and we talked about generally with cartilage, it's really important that we allow for some sort of movement as we rehab. But oftentimes, if they're not going to have surgery, they're still going to probably have a weight-bearing limitation. So they're going to be asked not to do a weight-bearing for a certain period of time, as well as wear some sort of cast or boot. During this time, if we can, again, normalize the range of motion and joint mobility, we're going to do that. So we're going to actually do joint mobilizations as well as active range of motion to help make sure they keep their range of motion. And then we're also going to recognize that this injury might have happened because other muscles or other joints aren't working as well as they could. So we're definitely going to look at the hip and the knee and make sure that we are strengthening at the hip and knee, watching gait, obviously, and seeing if there are other issues that need to be addressed while they're rehabbing. Surgery is going to be indicated if they don't respond to conservative treatment, which you'll notice is very true for a lot of these things that we're talking about through this postoperative classes. Also, if there's a large lesion. So if it's a bad enough hole, essentially, or tear in the cartilage, then they're going to obviously do surgery first. But you'll see that there's about a 50% success rate with conservative care and only 70% with surgery. So again, they're going to try to do some sort of conservative care first. And then if it doesn't work, then they'll go into surgery. So you'll see here in the picture on the bottom right that they can stage the injuries. And so again, if it's a stage 4, they're much more likely to do surgery. And then if it's more like a stage 1 or 2 or 2, it's a 2A, 2B, they may or may not. 2B, again, there's like a little flap in the cartilage if you look at that 2B, and so they're more likely probably to try to do surgery. And I have a couple of different pictures here of different techniques for surgery. So there's actually a couple of different options that the surgeon might use. And you'll see that these surgeries are actually pretty similar for different types of cartilage injuries. So we're going to talk about the knee. We're going to also just talk about other cartilage injuries, and you'll see that these types of techniques are very similar throughout the body, depending on basically what the surgeon is most comfortable with. They're going to choose a technique that they think is the best for helping to reproduce cartilage. So the first technique is called a microfracture, and basically what they do is they drill little holes through the cartilage into the bone. So at different angles of 3 to 4 millimeters apart and 2 to 3 millimeters deep, they're putting holes all the way down into the bone. And what you see in the pictures there is that then this bleeds. And basically what they're doing is they're getting down into the area where you can pull up more blood flow. So if you remember when we talked about cartilage and cartilage injuries, the cartilage itself has no blood flow. Remember, it's trying to get all of its nutrients from synovial fluid. In this case, the surgery goes down to where there is blood flow and helps to try to basically jumpstart new tissue growth by using this microfracture technique. Mosaicplasty actually takes cartilage and bone. It cuts a little piece, kind of similar to the same size as these little holes, and it takes it from the knee and then actually places it into the talus. So that's another option. And then the last option that you might see is what's called osteochondral autologous surgery. And in this case, they actually grow tissue in a lab. So they're taking tissue, again, probably from your own tissue. They're growing that tissue then in a lab, and then they're surgically inserting that tissue into the area where you have the damage or the hole or the cartilage flap, whatever it is. They take that out and they put in this newly grown tissue. So those are the different options that you have for trying to, again, repair this cartilage that has been damaged. Unfortunately, complications include adhesion. So again, we talked about how the talus is designed for dorsiflexion and plantar flexion. Unfortunately, complications include the possibility of getting adhesion, so you're not getting good dorsiflexion, plantar flexion mobility. Synovitis, which is just inflammation of that synovial fluid, which we know it can be bad because this is how we're getting our nutrients to that area. Significant amounts of edema, again, because the tissue is not healing on its own. Arthritis can also occur. And then some sort of, if they're doing that osteochondral surgery where they're replacing it with tissue grown from a lab, you may end up with non-union, so the lab tissue may not actually adhere to that area. So those are the complications that you need to consider following surgery. In terms of precautions, things that we worry about, the size of the lesion will definitely affect weight bearing. And the surgeon really is the one who's going to recommend the type of weight bearing and how long they're going to be non-weight bearing. So you'll see here, it's important that the patient understands that there could be non-weight bearing anywhere from 2 to 6 weeks. And it's pretty common. Again, the larger the lesion, the longer the period of time. So 2 to 6 weeks is a big difference. And your surgeon should be able to tell you how long that patient is supposed to be non-weight bearing. And so we want to make sure they understand that they're going to be wearing some sort of boot, hopefully removable boot, hopefully not a cast, for at least 2 weeks. And again, non-weight bearing for 2 to 6 weeks, depending on the size of the lesion, the area that's been damaged. So we joke about the fact that you may or may not get to see your patients pre-operatively. It's pretty unlikely in China that you actually get to see them before the surgery. But if you do, just letting them know, hey, this is how you do non-weight bearing movement. So you'll see this picture. It's a guy in crutches. He's using one foot. We want to make sure they know how to do that, how to get around with their non-weight bearing status during those first, again, 2 to 6 weeks usually. Okay, so let's go through how we do our rehab. And what you're going to see as we go through these is that a lot of these goals, a lot of the treatment is going to be kind of similar from pathology to pathology, but the time frames are likely going to be different, and the amount of intensity is also going to be different. And so what you'll see here with these patients is that we're not even really starting any type of rehab until week 2, or actually maybe 2 weeks after the surgery. So they're basically going to be non-weight bearing. We want to make sure that they know how to use crutches to get around. But the first phase of rehab, the protected motion phase, is going from weeks 2 to week 6 generally. And again, remember, if the lesion is very big, they may be non-weight bearing for a couple more weeks. So you may not start until week 4 or week 5. During the first phase, the primary goal is to protect that surgical site. So making sure that the scars, the incision sites are okay. Making sure they have good pain management, that they understand things like elevation and compression, the things that we would use to help decrease swelling. And at this time, we want to begin range of motion. So again, dorsiflexion, plantar flexion is the most important movements following the surgery, but we also need to think about inversion and eversion because that's part of the subtalar joint. So our patient education for this patient is going to be discussing when to and how long to wear the boot. We're hoping we have a boot option so that we can start doing treatment with them without the boot on. Again, that's always better than having to wear a cast. And so when they're in that boot, we're going to find out from the doctor how long they should be wearing the boot. And as I said earlier, we're letting the patient know that they could be non-weight bearing for up to 6 weeks if it's a large lesion, if it's a large injury that needed to be operated on. And so treatment during the first phase. So again, remember this is 2 weeks to 6 weeks, sometimes longer if it was a large lesion. And we're just primarily trying to get rid of the edema and trying to make sure that the rest of the foot is very mobile. So we want the midfoot and the forefoot to stay very mobile. We're also then using lots of modalities during this time. Like we said, compression, maybe some electric stimulation to help with the edema. So our focus is making sure that they are more comfortable during this first phase. Range of motion, we really would like to have the boot that can be removable so that you can do active range of motion and active assistive range of motion of the ankle. This is really important. Remember, we talked about cartilage in the last presentation and how important it is that cartilage has mobility, because we want to move that synovial fluid in and out. We want that synovial fluid to bring good good nutrition, all those important things that help for tissue to heal. And the only way that that can really happen is with range of motion. So making sure that we're teaching our patients to do consistent active range of motion, active assisted range of motion. You can even start some very basic isometrics during this time to make sure that the muscles continue to contract. And we need to get creative with finding non-weight bearing exercises for the core, the hip, the knee, but nothing where the foot is flat and pushing through, let's say, the bed or the ground. As we move into partial weight bearing, which again, most likely is going to happen during this phase, they're going to be able to start weight bearing more. We can then begin pool exercises if you have access to a pool. And we also, at about week 4, can start doing cycling with no resistance. So they're not pushing through the pedals, but they are doing that range of motion that you can get from a stationary bike. To progress out of phase 1, they should be able to have some weight bearing. So again, this is usually the surgeon's decision to say, hey, they can start doing partial weight bearing, and we need to be able to see that they can do partial weight bearing without pain, without increased pain. So this idea of being able to control the pain at this point is very important. So we move into phase 2 now, and you'll see phase 2 is usually at week 6. Again, it might start later if you're working with a patient who had a larger lesion, and it goes for about 6 weeks, so from week 6 to week 12. Our goal is that by the end, we have full weight bearing for these patients that is pain-free, as well as full ankle range of motion. So you'll see here I have a little chart that shows what normal range of motion looks like, as well as functional range of motion. So this is the range of motion that's necessary for things like gait and stairs. And so for plantar flexion, they need at least 20 degrees, and for dorsiflexion, they need at least 10 degrees. And so that's important that they have those things to be able to do normal movement. But of course, we would love it if they had more. So we have sort of the normal ranges there as well. By the end of the second phase, we also really want their gait to look as normal as possible without an assistive device. Okay, so this is the main goal for the second phase. So by 12 weeks, they should be walking pretty normally at that point. And we're educating the patient to help them start to get to that, again, normal gait, normal weight bearing, and not having to use the boot any longer. Hopefully their pain is under control so they don't need it anymore. Our treatment can also include a lot of manual therapy for possibly soft tissue of the calf, swelling, but primarily joint mobilization. So if they've been in a boot or they've been not allowed to move for a period of time, not only do we need to work on dorsiflexion, which we know is very important and probably the most important thing at this point, but we also need to be looking at the subtalar joint. Remember, subtalar joint does inversion and eversion. We need to make sure that that's allowed because it's important, as we talked about earlier, for gait. Sometimes the midfoot can also get very, very stiff, and areas like the big toe because they're not using push-off very well. And we'll talk about that stuff a little bit later, but just recognize they will likely need joint mobilization, gentle joint mobilization initially, but then more intense joint mobilization of the non-surgical areas throughout this phase. Treatment, we're going to start adding some resistance to things during this phase. So you'll see we're going to start doing some TheraBand exercises, maybe inversion, eversion, dorsiflexion, plantar flexion in non-weight bearing. And then we're going to progress towards these weight-bearing exercises. So bilateral heel raises, progressing to 1 foot heel raises, things like squats. You can do wall sits. Obviously, calf stretching. If their soft tissue is very tight in their calf, we definitely need to start making sure that they get that soft tissue stretched out so that they can do dorsiflexion, because dorsiflexion is so important at this phase. We'll add some resistance to the bicycling at this point. And then we're going to also start doing proprioception and balance activities. And you'll see that we can kind of play with this. I'm hoping we get to do some sort of labs. We can talk about what all of these things look like during the labs. Balance and proprioceptive training, we're generally doing kind of the same progression with everybody. Again, depending on their age, you might have to start with really basic balance things, but a lot of these people are probably younger. So you're going to start with some sort of tandem balance activity, working towards single leg stance. You're going to work from stable surfaces to unstable surfaces. You're going to work with eyes closed and eyes open. You can start doing some different types of hip resisted exercises as well to help with balance and single leg stance. And for us to move from phase 2 to phase 3, they really should have full range of motion, as I said earlier. Also, that gait, you need to make sure that their gait is normal. And again, we can kind of go through these things in lab a little bit more. If you've never been introduced to this gait stuff that I talked about earlier, it's a lot to take in with just this one slideshow. So I completely understand that. Gait is something that you can spend months being educated on, and it's still probably a little bit hard to understand it. So don't worry about it. Hopefully in lab we can kind of work on that. But again, the idea is by the end of this phase, your patient should be walking pretty normally and should be able to tolerate single leg stance. So phase 3, you'll see, starts at about week 12, again, maybe a little bit later than that, and goes for about 4 weeks. And during this period, we really want to have them back to their normal life. So you'll notice that we call phase 3 the functional sensory motor training phase. We're going to call it that for every one of these patients after every one of these surgeries. It's during this phase that we want everybody to be back to doing their normal function at home. They should also have some sort of exercise program that they've established during this phase so that they are comfortable with being home and doing exercises, not having to be in the hospital full time. And it's important that they understand that we're not getting to intense running or high impact sports during this phase. So we're waiting a while before we get to that stuff. We're going to start some plyometric training, but we're not doing a huge amount of impact because that cartilage is still healing. So we are going to start doing a lot more strengthening though. So these are going to be progressive strengthening things, single leg squats, single leg heel raise, lunges. We can start playing with the elliptical trainer to help progress to running, as well as start some plyometric training. But again, we're not doing intense running or intense jumping or things like that right now. We're also going to progress the balance. So we're going to start doing some foam roll kind of balance activities, some Bosu. I love Bosu for this. Bosu is also kind of fun. If you flip it over so the flat side is on top and you have them do things like squats, you're going to be able to see and they're going to be able to feel their weight bearing status. They're going to be able to feel if they're equally weight bearing on both sides, which is what we want, right? We want them to not, at this point, at this phase, we want them to not compensate for their surgical side. We want them to be equally weight bearing. And the Bosu is kind of a nice way to see that and make sure that that's correct. So to progress, we're not going to go into detail about the Y balance test, so you can look it up if you want to. But basically, when you do the Y balance test, you're measuring how far they reach in those three directions. And the idea is that they are at least 85% of what their good leg is. So when they're standing on their involved side, they need to reach with their good leg. And when they do that, it should be, again, the distance should be at least 85% of the distance that they would do with their other leg. You also want them to be able to hop, do single leg hopping during the end of this phase, to be able to progress then to sport-specific training, which is the last phase. And so sport-specific training usually starts about week 16, so 4 months following this kind of surgery. It could be, again, a little bit later. And during this phase, we basically sent them off to kind of do their own thing. And we know that they can go back completely to return to sport by using what's called the hop test for the ankle. And so there's a couple of different kinds of hop tests. You can do a single hop or a triple hop, crossover hop, or a 6-meter hop for time. And those all, we oftentimes do all of those together. And the idea is that, again, this is going to be at least 90% of the other side. So the distance or the time should be 90% compared to their uninvolved side. So that is a nice way to just to say, okay, you're ready to kind of return to running and plyometrics and any type of sport that you might be wanting to do. Of course, during this fourth phase, if you're still seeing your patients, you're going to start doing those specific sporting events and activities and making sure that they are safe and that they look good, that their movement patterns are appropriate with any of the sports they might want to return to. Okay, here's a list of references. You should have access to this. We'll have references at the end of each of these slideshows. Again, I know this was probably a lot of information because it's the first one, and we do want to introduce important things like gait and some ankle anatomy type things that maybe you didn't know before. But just recognize that each of these presentations are going to follow the same pattern. So you're going to start hearing things that sound very similar over and over again, which I think is a good thing. It's good to be able to get repetitive information so that you can learn it more consistently. So it's great to be able to do this for you guys. Hope you enjoyed, and we will talk again soon.